Right. Hi, everyone. Welcome to this webinar marking World TB Day. My name is Yannicka. I'm the Senior Parliamentary Advocacy Officer for TB at Results UK. We're really delighted that you could join us today. We're going to spend some time today learning more about the experiences of people affected by TB, which remains the world's biggest infectious disease killer, and how their lives might be affected by the ongoing COVID pandemic. I'll shortly be handing over to Aaron Oxley, who's the Executive Director of Results, to make some opening remarks. But before I do that, just a few housekeeping points. We're going to be sharing video clips from the Unmasked documentary, followed by some discussion with our special guest, Dr. Zolelwa Sifumba, and that will probably go on till about 7:15. Then we'll go to a Q&A, where we'll also be joined by Dr. Martin Ruwald from FIND. To help us sort out questions, it would be great if you could use the chat function, which is at the bottom of your screens, so that we can sort out questions, and let us know your name and where you are calling from. Also, please make sure to try to keep your phone lines muted so we have as little interference with the videos and with the line that we have to South Africa today. For those dialing in online, the mute/unmute button is at the bottom left of your screen. We are also recording this webinar, so do bear that in mind if you've got your video on. See whether you're comfortable with being saved on the Results UK website for all eternity. With that out of the way, I'm delighted to introduce Aaron to say a few words to kick us off. Aaron.
Thanks, Yannicka. And I just want to start with a big thank you to all of you who've taken time out of your evening to join us for this World TB Day webinar today. So yes, as Yannicka said, my name is Aaron Oxley. I'm the Executive Director here at Results, but of course you're not here to see me. You're joining this call to hear from our very special guest speaker. We're really delighted to be joined by Dr. Zolelwa Sifumba. She's an incredibly inspiring doctor, advocate, and multi-drug-resistant TB survivor from South Africa. Zolelwa was actually meant to be in London this week on a Results UK advocacy tour. She was supposed to be speaking with policymakers about the role the UK government can play in tackling TB around the world, but as you can see, that hasn't happened. TB continues to be the world's deadliest infectious disease. An estimated 10 million people fall ill every year, around 1.5 million people dying. That's about 4,000 deaths every single day, despite TB being an entirely curable disease. Now, at Results, we've worked on TB for quite a long time. We're really excited by the amount of progress we've seen in recent years, with political leadership increasing, more investments, and some amazing scientific breakthroughs. But we're under absolutely no illusion that there's so much more left to be done. Now, Zolelwa and our TB team in London were ready to spend all week talking about all of that. And yet today we find ourselves in a very different situation to the one we were in when we started planning for World TB Day 6 months ago. This outbreak of the novel coronavirus, COVID-19, has fundamentally changed the way that many of us in the UK live our lives. It's exposed the weaknesses in our own health and social care systems, and it looks to dominate people's lives and conversations about health for a number of months. Those of us that are working in global health are rightly worried about the impact that this pandemic's going to have in low resource settings, where governments, economies, and healthcare systems are much less well equipped to contain the spread of the virus and provide people with the help that they need. So the team at Results have tried their very hardest to find a way of marking World TB Day this year to ensure that the voices of TB affected communities and of healthcare workers in countries around the world are at the heart of our discussions, and to find ways of informing and inspiring colleagues and campaigners across the UK. We're really delighted to be welcoming Zolelwa to talk about her experiences with MDR-TB, her life as a doctor today, and how things might change as a result of the COVID-19 epidemic, and what we can do to support global efforts to tackle both TB and the coronavirus pandemic. We're going to also show some clips from a recent documentary film that Zolelwa featured in called Unmasked, We All Breathe. That'll hopefully add some additional richness to our discussion. We're also equally delighted to be joined by Dr. Morten Ruwald. He's the head of the TB program at FIND. They're a product development partnership that specializes in the development and rollout of new diagnostic tests, including ones to diagnose TB and drug-resistant TB. He's a medical doctor with over 15 years of professional experience, including developing many of these tests himself. So he'll be there a little later on. Well, he's here on the call now, but he'll join us in more force later on to help answer your questions as part of the Q&A at the end. I also want to give a really big thank you to Akana Media, who produced the documentary Unmasked, and who gave us permission to use the clips that we're going to show tonight in the webinar. If you'd want to watch the whole film, you can find it on Amazon Video, and I really would recommend tracking it down and watching the whole thing. Now, before I hand back to Yannicka to moderate today's webinar, I think it's important to set a few ground rules. First of all, at Results, we place a great deal of emphasis on being an inclusive, supportive, and empowering space. That means we're not going to tolerate any negative or stigmatizing language. Now, we can all make mistakes sometimes, but I'd like to ask us all to choose our words really carefully and thoughtfully when we're engaging in discussion. In that same vein, the COVID-19 outbreak is a scary thing, and there's still an awful lot of stuff we don't know. So we want to ask for your patience and ask that when joining the discussion on that you avoid speculation and rumor and instead focus on evidence-based recommendations and finding ways to support each other. And lastly, there are going to be people on this call that for a whole variety of reasons are more vulnerable to infectious diseases and the shocks that happen to health systems. Tonight's subject will be personal to them in ways that might not be to you. So please be mindful of that when engaging in the discussion, as well as when you leave the call today and talk about what you've heard with friends and family. So thanks again for joining, and please do share your main takeaways from the webinar on social media using Results UK's social media toolkit for World TB Day. We'll put a link in the chat box to that momentarily. But to get us started properly, I'm going to hand back to Yannicka. Thanks.
Thanks, Aaron. So we're going to start off straight away with a quick clip from the documentary Unmasked. The documentary was released in 2019 and follows the story of 3 South African doctors, Zolelwa included, who contracted MDR-TB while they were working. Zolelwa is one of them, and this clip explains in a little bit more detail what TB is and why we're here. Just a friendly reminder for folks to keep their lines muted while we try to play this call. This involves changing screen shares of one of my colleagues, so give us a second if there's a slight break while we sort out the technology.
TB is a contagious bacterial infection that most commonly attacks the lungs. It spreads from person to person through the air when someone with TB coughs, sings, or speaks.
TB has actually killed more people than smallpox, bubonic plague, malaria, Ebola, cholera, influenza, HIV/AIDS itself, all of them added together.
TB is now the leading infectious killer in the world. Last year, there were more than 10 million cases of TB, over 500,000 of those MDR. As significant advances were made in developing treatments for heart disease, cancer, and HIV/AIDS, little changed for decades in TB treatment.
We went to sleep and we thought we have defeated TB simply because it has been there for more than a century, for centuries actually. Develop no new diagnostic, develop no new drugs. Well, it has become a personal crusade because I remember my primary school was next to a hospital. There was a special TB ward where the TB patients, they used to spend many, many months. We will look at these people as different people from ourselves because they've got TB, they've been sentenced. Christmas, generally, it's a socio-economic disease of the poor. And so it's regarded as a lowly disease, I suspect. That's where the stigma came from. TB affected 10 million people globally last year. Unfortunately, only 6 million are on treatment. There's 4 million there. We call them the missing 4 million who are out there and nobody knows where they are.
For now, I'm delighted to be able to introduce Zolelwa, a junior doctor from South Africa who contracted and successfully beat MDR-TB in 2014. Zolelwa, welcome. Thanks so much for joining us. We would have loved to have you in London for this event, but thanks all the same for calling in quite late at night from your home in Durban. To start us off, can you tell us a little bit about yourself and the work that you do today?
Hello, everybody. Thank you very much for having me today. Yeah, as Janica said, my name is Dr. Zolelwa Sifumba, and I'm a medical doctor from South Africa. I'm currently based in a small town in KZN called Harding, and I'm currently doing my community service, which is basically a year of working out in Harding. Yeah, so I'm doing that while I'm also still obviously continuing with the TB work that I do. Yeah.
Brilliant. We're so pleased to have you. So we're going to show or attempt to show another clip from the video. We hope the transition is a little smoother, but bear with us. This second clip is about the process that Zolelwa get diagnosed with MDR-TB, which you'll find out is quite often not a particularly easy process.
The symptom that I had that led to the diagnosis of my TB was actually a lymph node. It was literally just 3 by 3 centimeters big. Me and my friends made a joke out of it. Because we were young medical students, so we went around firing differential diagnoses. Then it grew, and I started to realize that actually I need medical attention. So I went to the doctor. There's a certain way TB looks when it's in your lymph node. It's called caseous necrosis. So the doctor, who knew I was a medical student, turned it into a lesson. I was like, hey, do you know what caseous necrosis is? And I was like, TB. And he's like, yes, you've got it. So I looked at him and I was like, okay. Really? No. Then on a Saturday morning, I got a phone call. They said, no, look, your results have come back. So you've got MDR. At that point, the stats were that only 60% of MDR patients on treatment will make it through. Meaning there was a 40% chance that I was going to die.
Hi everyone, I'm seeing some messages on the chat that the audio is still a little challenging. We will try to sort that out as the clips progress, but please do bear with us for the time being. Zolelwa, coming back to you, can you talk us through that moment a little bit more? Why did a TB diagnosis shock you so much?
So to be quite honest, I mean, as medical students, we knew a lot about TB, and we knew that there'd be a lot of, patients that had TB in the ward, but it kind of didn't make sense to us that, okay, if we were exposed to it, it means that we're at risk of contracting it. So really for me, the shock was just that I didn't think I was at risk of getting TB. Just because the pictures that you always saw of someone with TB was somebody who looked like they were dying, and the usual demographic they tell us about is the person that's living in a 1-bedroomed house and sharing the house with 10 people and is of low socioeconomic status. And I thought to myself, look, I'm of middle socioeconomic status. I've been to good schools. I'm well educated. I'm not sharing a house with so many people. So it doesn't make sense that I'd be able to get it. But actually, what I didn't know was that as healthcare workers and students, our risk of contracting TB is actually quite high. And it made sense. I mean, if afterwards it made sense that, look, if I'm exposed to this disease for long enough, then it means that I'm at risk of contracting it. So the shock really was that I had TB. And TB just had all these negative connotations and all these myths and stigmas attached to it that kind of just were thrust upon me when I was diagnosed with TB. And, you know, it was a really tough process to really just accept that, look, this is your life and this is something that's happening to you now, and you need to take this medication now or you're going to die, you know? So yeah, that's basically what the shock was. And I didn't know if I was going to survive. But yeah.
We're going to come to a few of those themes, particularly around the stigma piece later on in the conversation. In that clip, you talk about having been surrounded by doctors, and as a medical student, I would assume that you had relatively easy access to someone that could give you a TB test. That's obviously not necessarily the standard for most people, especially those kind of demographics that we traditionally associate with being at highest risk of TB. How does the kind of your diagnostic experience compare to that of the people that you're seeing in hospital wards as part of your day-to-day work?
So fortunately, when I, got TB, I was a medical student. So there was kind of already a process that I could follow in terms of seeking medical care. So what had happened was that I was just told to go to the hospital that was across the road from our medical school, and they would be able to sort of do tests and diagnose what was going on. But usually, so that was Curtis Care Hospital, which is a tertiary hospital, and usually people in South Africa will, first of all, the first point of contact is the clinic. So we tell everybody to go to the clinic and start at the clinic. And the clinic, if the clinic picks up signs and symptoms and they're pretty sure that they can make this diagnosis without an X-ray, they'll just do the gene expert, and the patient will be expected to come back in 3 days' time to come back for the results. Unfortunately, because our system is a bit broken, people end up having to be referred to sort of secondary level care or tertiary level care, so the bigger hospitals, to get the same diagnostic process, which obviously increases the amount of days that they have to wait, because the travel to the hospital is longer as well, meaning that somebody could wait about a week just having the symptoms and having done a sputum test as well as an X-ray, and they'd have to wait for about a week before they'd get that diagnosis. And sometimes we even have problems with sort of initiating the treatment. So fine, the person's been diagnosed now, but sometimes there's drama at the clinics where they won't have a certain medication and they'll have another medication, or yeah, just working in a low resource setting is not really the greatest. So some of the times, and a lot of the times, people will be delayed because really it should be as simple as someone going to their local clinic and getting the test done, and a gene expert is done within 2 hours. If obviously you have the machine. So where I am based, the gene experts actually have to travel 2 hours before they arrive where they need to be tested. So there's a lot of potential stop and starts, when it comes to, a patient, that is coming to the clinic or coming to the hospital to get a diagnosis. But a lot of the time as well, people will be sick and the clinic will be far, or getting to the clinic will be expensive or difficult. So they'll kind of just, be at home while they deteriorate, while their family can see that, look, this person has something that's clearly wrong with them. And while they're deteriorating at home, they're spreading the disease as well. So obviously, because we have a lot of people that don't have enough money to go from home to get to the hospital. So those people eventually come back bedbound, and just really sick. And obviously in that time, they've infected so many people that live with them. So yeah, the process can be simple, but it can also be quite difficult for a person to navigate.
Yeah, thanks for talking us through that, and I'm very glad that we've got Morten on the phone to engage in the discussion later, coming from the kind of perspective of someone that specializes in improving diagnostic pathways for people in low resource settings, particularly. I want to move us on to the next clip, which looks at your experiences of the MDR-TB treatment that you were prescribed, which many of the people on this call will know to be an incredibly grueling one. Just a note also to the folks on the phone, the documentary, as I said, doesn't just focus on Zolelwa. There are 2 other doctors that are featured in the documentary, and this clip will include a short excerpt from the story of Arlette, who is a surgeon and who also contracted MDR-TB. Della, let's try to roll the clip.
I remember the sister coming with this massive tray full of tablets. I was the sole receiver of this tray of pills. The treatment involved more or less 40 tablets and the injectable regimen every day for 18 months. It's a massive amount of medication with a massive amount of side effects. Things quite suddenly and quickly and progressively deteriorated from there. I experienced severe nausea, vomiting. Then I started to experience a lot of confusion and memory loss. Most days I couldn't really remember what I did in the morning. It was just astounding to me that I could come from a week ago, this highly functional, highly productive individual, to a person, not even resembling a person, groveling on the bathroom floor, not able to even take a shower because I can't even open up the tap. I started to realize that the side effects might be much worse than I originally anticipated.
So I started off getting the injections at the clinics, which was terrible because they just like jab it in, push it in. Now you must leave. If you start to cry, they're like, no, you're not going to cry here. Outside. The pain from the injection. I describe it as hot lava being injected into you. It's difficult to sit, to stand, to sleep, to walk. There wasn't a day that went by that I didn't think about killing myself. All the things that I felt were important about me as a person had gone. Friends, family, school. I started saying goodbye to people. I started giving things away. Yeah, I was basically getting my affairs in order. Nobody could see it. But I was preparing to die.
So that is an incredibly difficult clip to watch. it doesn't sound, from how you described the nurses that gave you the MDR-TB injections during your first phase of treatment, it doesn't sound like they were the most supportive. Was there any additional support that was available to you to manage these side effects throughout your treatment?
But the support that I got, support that was sort of part of a system of treatment and care that was given to patients. I sort of, in my search for help, I found some TB survivors online, and I started sort of chatting with them, just to get, more information, because I didn't know much about TB in terms of going through it as a person. So basically what I did was I looked for like support groups that were in the area, and there was a support group for TB patients at the one clinic that was quite far from where I lived. So unfortunately I could only go once. But I think most of my support really came from a group of TB survivors that were part of an NGO from the Western Cape called TB Proof. And basically, the people in TB Proof are just a group of healthcare professionals that have, a lot of them have had experiences with drug-sensitive and drug-resistant TB. So a lot of them knew what it was like to actually go through treatment. And I think that was probably the life-saving support that I got, because I think there's nobody who understands something more than someone who's been through something. And fortunately, because I had these contacts around me, I could, call them at any time of the day to say, look, I'm experiencing A, B, and C. What can I do about it? I need, help with this. I need help with that. They advised me in terms of getting hearing tests, that, basically my support system was a group of TB survivors, and that helped because they understood, but it helped because everybody else around me didn't understand what I was going through. So because they understood, because they had been through it themselves, they were able to counsel me through the difficult times. But I think it's very problematic that the system doesn't include, psychological support for patients, social support for patients, because it's very difficult to stay on treatment. For instance, if you don't have food in the house, it's very difficult to stay on treatment. For instance, if you're the breadwinner and if you stay at home sick and take pills, it means that you can't go outside and work for the family, So I think it's very bad that there isn't any kind of social support, and I had to look for the social support that I had.
Yeah. We'll come back to TB Proof at the end. They're in the last clip. But there's a bit in the film that we won't be showing a clip of today, where South Africa introduces bedaquiline, a new MDR-TB drug that has fewer side effects, into their standard MDR-TB regimen. And that removes the need for the injectables that you described in that clip as being so brutal. What difference has that change in policy made for people with TB in South Africa today?
So that injection was seriously painful. You felt it, hours after the injection. So I think, I was very happy when our minister announced that we'd be removing the injectable, because for me, the injection was a huge stumbling block. It was, the part of the treatment that everybody hated the most, because you're still in pain from the same injection the following day and you need to get another injection. So a lot of people, ended up leaving treatment. I, seriously wanted to quit treatment because of those injections, because what had to happen was I had to travel to and from the clinic, sort of dreading the pain that was coming, and away from the clinic in pain, so unable to continue with my day because I was in so much pain. So I think the injection was a huge stumbling block. The injection made me want to stop. And eventually, I fortunately had the funding to get a port inserted because I couldn't tolerate anymore. I mean, after 1 month, my bottom was black and blue. I wasn't able to sit. I wasn't able to stand. Water hitting me on the shower was painful, you know? So personally, I feel it did a lot for patients to not have to be on the injection because the injection is just, it was too painful. And for me, honestly, it was inhumane.
Yeah, so that access to bedaquiline has obviously made a huge difference. For folks on the call, South Africa was the first country to introduce bedaquiline and remove injectables from their MDR-TB regimen. The World Health Organization now recommends that countries stop using the injectable and only use bedaquiline. There's a question from Jill in the chat to spell the name of that drug. I will do that while the next clip is playing. But it's just to say to people on the phone that that is not yet the standard. And there are thousands of people around the world that are still being treated with the use of those injectables. And there's a big campaigning effort to try to change that. We're going to move on to the next kind of theme and clip for today. There's another side effect that comes with a TB diagnosis and treatment. Zolelwa mentioned it earlier, and that is isolation and stigma that's still associated with the disease. In the next clip, we'll hear from Zolelwa, but also from Darlene, the third doctor that's featured in the Unmasked documentary, who is also a doctor in South Africa. Let's play clip 4.
I was afraid to tell my dad. My mom told him, but he didn't really address it with me. He was very closed off.
I always tell you, it's not how many times you fall. You know, that's how life is. It's how many times, you know, when you fall, you can rise up again.
Essentially, it just felt like my whole sort of immediate family had rejected the fact that I was sick. And I didn't actually tell them the stats. I didn't tell them that there was a 40% chance that I was going to die because I'm the eldest child. I've never liked to be the one being taken care of, so I usually just act tougher than I am.
Darlene has spoken about the guilt that she felt, but the fear from everyone else is a completely different thing. So her so-called friends and colleagues and support network, I can count on these 2 hands the amount of people that actually got into touch, and only on one hand the amount of people that visited her in the hospital. And she'd been transformed from this selfless, admired colleague into something and someone that people want to avoid.
People think TB patients did something wrong. They have HIV or some other chronic illness. They do drugs. There are so many false beliefs out there.
The first 2 years were just survival mode, just trying to get her through this treatment. But then the question arose, if it was so difficult for her as a doctor, how on earth can anyone else in less fortunate circumstances get through it?
That feeling of isolation is, I think, something that a lot of people, particularly in high-income countries, are experiencing for the first time in a much, much milder form as these lockdowns come into force across Europe and much of the world at the moment. Can you talk us through what the impact of stigma is for the TB response in South Africa and what it is that we can do to tackle it?
So stigma has a very negative impact on the response, because basically the stigma is that if you got TB, it's because you did something wrong, or you know, your immune system was weak. So basically the fault is yours. And And essentially, if the fault is yours, you have to kind of find a way by yourself. But the problem is that TB is not a thing that comes to people that are only at their weakest, you know? TB is not a disease that just goes after people that are HIV positive and diabetic. It goes after fit people, you know? And the reason is because we all breathe. And, you know, if we remove, you know, the stigma around it and people get to understand that this really is a disease that affects us all, no matter our socioeconomic status, no matter our race, no matter this, no matter that. And I think if we begin to understand TB as that, then we'll understand that actually it's all of our problem and we're all supposed to be a part of the response. The stigma makes the response belong to the victims, you know, when actually this is a disease that all of us can contract, meaning all of us should be part of the response and all of us should get educated around it because, of course, it can affect all of us. And then your second part of the question is how we can effectively tackle it. For me, education. Same as, you know, kind of while we're in this crisis that we're in, this global crisis that we're in, education is effectively the one way for people to break the stigma and to break the myths, because education means that they're getting the correct information about TB or about whatever it is. And with the correct information, you're more able to make better choices, you know? For instance, if you understand that TB is something that can be spread in public transport, when the windows aren't open, what you can do is whenever you're in public transport, you can decide to open the windows. And effectively, that's you protecting yourselves and that's you protecting the people around you. So that's why I say education, because it teaches us how to act sort of in this time. And it teaches you, you know, the things that you need to do to essentially save yourself. Yeah.
I think that's a really, really powerful statement. I particularly like the phrase you use, stigma makes the response belong to the victims. And I think we're all becoming increasingly aware that in order to tackle pandemics, epidemics, infectious diseases, and kind of global health more broadly, it is a question of solidarity, and it is a question of all of us working together, irrespective of whether it is us that is likely to fall ill tomorrow or someone down the street. Your focus on education also brings us nicely onto our final clip, where you talk about your decision to become an advocate and campaigner.
When I was diagnosed with TB, I knew nobody with TB. And that changed when TB Proof came to speak at medical school.
People should not be lucky to survive TB without it.
Deline was sharing her story, and I couldn't relate to her life or anything like that, but I could relate to the side effects that she had had. I could relate when Deline spoke about rejection. I could relate when she spoke about stigma. I would not be here today if I had not met Deline, if I had not met Arne. I would be dead. So what I decided was the next time TB Proof spoke, I decided I was going to speak. So let me start by saying, when I got TB, I was convinced that I didn't have TB because in my mind, TB was for the patients. I was the student. We're failing as a healthcare system to tackle TB. The fact that people are still dying of an illness that has been around for so long, that is failure.
So we're about to start our conversation with the results campaigners that are on the line. Many of the people on the phone have advocated on TB for a number of years. This month, for example, they wrote to the minister responsible for for a large portion of the UK's research and development budget, calling for greater investment and coordination of global health research. In addition to Zolelwa, we also have Morten Ruwald on the line. Morten, as Aaron says, leads the TB program at FIND, which is a product development partnership. and we'll be able to answer your questions about research and diagnostic capacity in low and middle income countries. Morten, would you briefly like to introduce yourself and the work that FIND does before we get going with the questions?
Sure. So as you said, FIND is a product development partnership. So we try to address some of the market failures by trying to sort of lower the bar for investment in diagnostic solutions for low and middle income countries. And we cover many different disease areas outside of TB. It's also antimicrobial resistance, it Hep C, HIV, malaria, neglected tropical diseases, and our group in pandemic preparedness are quite busy at the moment, looking at more than 200 new diagnostic solutions for COVID. So in my program, in the TB program, we're trying to develop new diagnostic solutions that are simpler and much more affordable and faster to results, and importantly, as we heard in the story here, available at the point of need. So we're working on both what we call molecular diagnostics. So that is these drug susceptibility tests that are proving very, very important to protect these new drugs that are coming out with bedaquiline at the moment. For instance, there's no really good diagnostic to make sure that resistance to this drug is being picked up and patients are put on other treatments. And if we cannot capture that, then we are generating resistance to the other drugs in the regimen. We're also working on urine-based diagnostics, super quick things, digital chest x-rays, artificial intelligence, a lot of different things in the TB program.
Brilliant. Thank you so much. To start us off with the questions, I think we've got Kathy on the line from Edinburgh to kick us off with the first question. Kathy, can you unmute yourself and tell us what you want to know?
Okay, well, thank you very much. It has been very interesting to hear all of this. And I think that part of my question's a bit redundant, because one of the things I wanted to ask you was what motivated you. And I think that you've answered that to a large degree already. But if you want to expand on any part of it, especially how you think that you can get the psychological support. And also, I wondered if you could suggest anything that we could do to support you over the next 12 months, how we in Results around Britain can do something.
Zolelwa, do you want to take that question to start with?
So if I heard correctly, the first question was what made me sort of decide to be an activist, or sorry, I'm just, okay. Yeah, so the first time I heard sort of someone speak about TB was at my medical school, and it was Deline, who was also on the documentary. So when she was talking, I mean, the students were listening, but they weren't really, focused, on what was going on. Up until I stood up, and I guess I drew people's attention because people knew me. I was a year above that year group, and I was in res with a couple of them. So everybody knew me already, So what stood out for me was the fact that everybody kind of paid attention when I spoke, because I was one of them and I was speaking as one of them and telling them about issues, that face us, And anyway, fast forward to a year later, on the campus at medical school, when I got TB, not many people knew about it. Not many people even knew that people on our campus had TB. But when I spoke up, you know, there was a lot more knowledge available around campus, and there was a lot more awareness up until a point that one of the year groups actually refused to go to a TB hospital without being provided, you know, the proper protection gear. And usually as medical students, we don't refuse those kinds of things. You know, even if you're at risk, you'll go because your professor tells you you need to go. But this whole year group decided to say no because they had understood that they were also at risk, and they decided that they were going to put their feet down, and not go. So they actually didn't go, which was the first time sort of in history of the trip. And I like to think that my work at the medical school played a big part in conscientizing the students to the fact that they were at risk of getting TB, to motivate them to change their behaviors in terms of their use of the protective gear. So yeah, that's basically why I continued, because I saw that I was making a difference in young people's lives, and I think less and less people were getting TB. And you know, when people were getting TB, because I had spoken about it, they were able to approach me at medical school and say, look, I think I have TB, what should I do, you know? Yeah, and the second question was how you guys at Results can support like me as an advocate. So I honestly, over the next year, I'm trying to figure out a path in which I can go down in terms of further studies. I'm trying to become, well, I am already a global health advocate, but I'm trying really to branch out. I want to do, you know, educational series that are accessible to sort of your everyday people, you know, short videos that can be sent around so that people, you know, can get, and these short videos basically consist of important information when it comes to health education. Because something that I've seen sort of in my everyday job is that a lot of the people that I come across don't know much, you know, about simple diseases. They don't know much about what to do when somebody has a seizure. They don't know much, you know, so I'm trying really, you know, to kind of define the path that I want to take. And I know, you know, there probably isn't just one path, but I'm really just trying to get myself out there as a sort of a thought leader when it comes to health education and support as well in terms of the diseases themselves. Because I've been through TB, I know that something that's really lacking is support for people with TB, you know. So those are the kinds of things that I want to sort of nail down on. And, you know, as much as, yes, I'd like to spread these kind of messages in South Africa, I'd like to be able to spread them globally. And yeah, and obviously I'd like to continue, you know, sharing my story and sort of educating people on the fact that, you know, yeah, TB is out here and it really doesn't care. As long as you breathe, you know, you can get the TB. So I'm really just, yeah, trying to find my way as a health advocate and trying to, you know, there's not a lot of support for health advocates in the world. I've just realized, you know, a lot of the things we go to, yes, they do support us, but it becomes difficult to, you know, really just branch into a career of advocacy itself.
Yeah, there's a lot of campaigners on the call who will have advocated, particularly around the replenishment of the Global Fund, which is, I know, something that you were really actively engaged in. And you said something earlier about having kind of seen the success of your advocacy because you were one of the people that you were speaking to. They could identify with you, and I think that's certainly something that our grassroots know lots about when they're speaking about sometimes politically quite unpopular things in their own communities. Morten, I wonder whether you also want to have a stab at answering that question. Why did you get involved in TB, more on the science side than the advocacy, and what can the Results UK grassroots advocates do to support FINE's work in the coming months and years?
Well, my personal story is came from an interest in immunology. So from basic science, I went into research. I've always had an interest in global health. So I grew up in Denmark, where there's basically no TB. 600 cases a year, and all patients are studied with whole genome sequencing, the whole thing. So, it wasn't because I have seen a lot of TB as part of my work. But TB is a very, very fascinating disease. It's been with us for, basically since the birth of humankind, and it is a very, very clever bug. I am very fascinated by this bug. So there's a research fascination, but there's also, of course, I'm driven by that we can make a huge change. The diagnostics we have at the moment are not good enough. The drugs we have are not good enough. We can change these things with research. We need funding. We need people like you to tell the story about the need. This is probably where you can help us the most. Make some noise that our scientists are often a bit reluctant to do because of all our restraints about data and results and all these things. So spread the word that change are needed. And I think using the COVID crisis at the moment as a stepping stone to sort of tell people about isolation and about uncertainty and about all the things that all of us are going through at the moment.
Thank you so much. I think that actually brings us to one of the questions that I've seen in the chat. Matthew from London, you had a question about the impact of COVID. Do you want to unmute yourself and ask Morten and Zolelwa?
Thanks, Jannica, and thanks, Zolelwa, for joining the call and telling us your story. So my question is about COVID. I guess, for us right now, going through the process of kind of advocating on TB and the current COVID crisis that's happening, what would be really great is just to kind of understand what the impact of COVID-19 is going to be on those that are already affected by TB, or sort of healthcare workers as well, working in sort of low resource settings like South Africa, to kind of understand how the two intertwine and kind of make things even worse, I guess.
I could start perhaps. Many of us in the TB community went to a webinar yesterday hosted by the McGill University in Montreal, and they set a pretty bleak scene on the future over the next couple of months. So at the moment, the COVID crisis has not really hit the high endemic countries, but the high TB endemic countries. But once this happens, we will probably be seeing quite a lot of damage on the TB programs. So TB is considered a pre-existing medical condition for COVID. And we know that those getting most affected by COVID are those with pre-existing medical conditions, and the structural lung damage you have from having TB in many patients after TB is definitely going to make the situation worse for those patients. And then there's the whole diversion of the workforce. Everyone is working on COVID now. Wards are being closed. Isolation wards are being closed for TB. Everything is COVID at the moment. The diagnostic services will be disrupted. The notification rates will go down because the whole notification system is not working. Supply chains will be disrupted. We can't even get diagnostic tests for COVID to the labs that are testing COVID at the moment. And this is our highest priority at the moment for many of these countries and labs. So we can just imagine what's going to happen for TB. Then there's the funding situation. Everything is going to COVID at the moment. The global financial collapse that will come after this. And then, it's the whole R&D is going to suffer as well. WHO are focusing on COVID at the moment. That's probably also going to change all the policy work that's happening. The whole social system will be affected. So these are some of the highlights from from the meeting we had yesterday, and it was pretty depressing.
Yep. I think, Doctors Without Borders brought out an article today talking about the intersection between TB and COVID, and noted that during the Ebola outbreak in Guinea, they saw a 50% increase in TB mortality after a year because of the impact on TB services. And I think that also points to some of the work that Results has been doing around universal health coverage. We brought out a report last year on how, called Brick by Brick, which looks at how these different health system infrastructures need to be built alongside nutrition programs, for example, to kind of build resilience into the system. Zolelwa, you are working with the Department of Health at the minute. Are you seeing some of the preparation for COVID to take place? You mentioned before the call started that South Africa is about to go into its own lockdown. What impact are you seeing on the ground?
So currently at the hospital that I'm working at, the town that I'm working in, we have no confirmed cases. So we've had quite a few people coming in, with some of the symptoms, saying that, they've got relatives that have traveled in and out of, certain places. So there's a lot of, people are worried about it. But people aren't really staying indoors because the hospital is quite full in terms of our outpatients department. So people are still, it's still life as usual. But I think people definitely obviously know about coronavirus. And now that we're going into lockdown, I think it makes the problem seem like, it's a lot bigger than what people anticipated. But we currently, at the hospital that I'm at, we don't have any confirmed cases. So currently what's happening is preparation. We're making sure that we've got enough N95 respirators, they're helping us get coats. We're being educated in a lot of the morning meetings that we attend. I think probably 80% of all meetings, the topic of discussion is coronavirus. And basically, to get us prepared as the healthcare workers, on the ground, and get us confident that we're able to, deal with the patients. But yeah, where I am anyway, we haven't experienced, any cases, so I can't speak. Obviously, in other hospitals in other parts of the country, they've already, they already have patients that have tested positive for corona. But it does seem we're getting ready to kind of fully divert our attention to coronavirus as soon as it touches the hospital, which is sad because it's like, when we completely shift our attention to that, how are our other services going to do? How are our other patients going to feel? Are we going to have time, to look after them? Are we going to have space in the wards? Because already at the moment, there is a bit of a ward crisis, because we have a lot of sick patients. So now coronavirus, poses a huge threat because we don't have enough space. And if we get to a certain number of patients that have tested positive for it, it's a small hospital that I work in. So we've got a few ventilators. We don't have many isolation rooms either. So I don't know. Well, we'll just have to see once everything really settles in Harding. But currently from where I stand, it's just a lot of people that are worried, having symptoms and just wanting to get them checked out.
Yeah, I think we're all kind of preparing for what is to come, but there is no doubt that this will have an impact on TB programs, and that long term we're going to be needing to invest much more aggressively than we have done in health systems, so that when something like this happens, we aren't in a situation where we have to talk about shifting our focus completely and moving it away from kind of other really, really big global health problems like TB. I think the next question is from Kate in London.
Hi. Can you hear me?
Yep, go ahead.
Great. Thank you so much, both of you, for joining us. I was just wondering, what investments and policy changes would you like to see in the next year, sort of both to improve TB programs, but also to make health systems more resilient to shocks like COVID, as we've been discussing?
Zolelwa, do you want to have a stab at that to start with?
Policy changes. I'm not, I haven't in sort of my advocacy journey been involved in a lot of, in terms of policy, but I think there just needs to be a lot more research just around, because I feel in South Africa, I mean, we saw that all of these things were happening around the world, but it sort of like seems like we were waiting for things to become really bad before, we realized, instead of, a lot of research going into, the coronavirus. I think as soon as it sort of showed itself on the planet Earth this time, we should have had a lot of research going into it and finding out, okay, what can we do? Fine, it hasn't reached our country, but what can we do to actually prevent it, from getting here? So I think, in terms of policies, there really needs to be some kind of system where, I don't know, trends around the world and diseases and the way diseases are moving around the world needs to be something that's always sort of researched and something that's fed back into sort of policy, so that the policies can actually protect us, from all the threats that come from all around.
Morten, are there any specific investments or policy changes that you'd like to see, particularly from a kind of diagnostic front for TB and global health more broadly?
So the policies are actually quite adaptable. The WHO is quite, when new diagnostics, for instance, arise, or when new trials on treatment results come out, then I think the WHO are quite quick to change. Well, then it sort of trickles down into country, and here the troubles, it might be that there's intention to intention to change guidelines, but if there's no availability of drugs or diagnostics or funding in the system to make things happen, then we can sit here in Geneva in our ivory tower and make great plans. This is about funding, focus. Global health is difficult. It's a lot of money. And you can't tackle TB without also addressing poverty, education, equality, all of these things.
Yeah, I think we are all very aware of that funding being very much needed to build more resilient health systems, and then to also deal with the aftermath of what will happen after COVID has gone its course. I think we've also got Egley on the phone from Birmingham. You had a question. Are you able to unmute yourself and ask it?
Yes. So my question is, a third of all people with TB are still unable to access diagnosis and treatment. Have you seen any progress on this in South Africa, and how was this possible?
Zolelwa, do you want to talk about it from the perspective of a doctor? Have you seen improvements in diagnostic access? And then maybe Morten can talk about the global picture.
I mean, there's definitely improvement. Especially, I think the biggest thing for us, one of the biggest things to happen was the rollout of the Gene Expert machine, because it means that wherever, there's a Gene Expert machine, which is, some of the clinics have them too, but a lot of the clinics don't. But wherever there is a Gene Expert machine, it means effectively people can be tested and a diagnosis of whether it's drug sensitive or drug resistant can, be given and treatment started, So there's definitely, with the rollout of the Gene Expert machine, it's, especially because not a lot of clinics have X-ray machines. So, those kinds of diagnostics aren't, fully rolled out yet. But yeah, So yeah, basically the gene expert machine at the clinic. The clinic is basically a person's first portal of entry into the public health system if they have a problem. So it means effectively that a gene expert machine is available, to a lot of the communities in South Africa now, which, was definitely one of the biggest improvements. But for me, I mean, I haven't worked, many years. I can't comment on, the whole of South Africa. But what I can see in KZN, which is where I'm from, is that it seems, unless people, I mean, the problem is a lot of people live far away from the clinics as well. So we're still not capturing everyone. There's still, people that, really struggle to access even a clinic. So it's difficult to speak on their behalf, but I think there's definitely been an improvement.
Morten, have you seen that at the global level as well?
Yeah, I'm also quite positive on sort of the future in diagnostics. There's quite a lot of cool things happening at the moment. So, for instance, there are new mobile X-ray machines. They are portable, weighs about 3.5 kilos. You can have them in a backpack. They're quite safe. You can set up a screen and do a chest X-ray. Then that links up to a artificial intelligence that interprets the X-ray and gives you a result within 1 minute without the need of a radiologist. So these things are coming now, and we're preparing a dossier for WHO that was planned for this summer. I don't know if that's going to change due to the corona situation. There's a new generation of urine LAM tests. So these are diagnostics that are on the market at the moment that are very good for patients with very advanced HIV with a low CD4 cell count. Then new versions of these coming out in the pipeline that can detect the presence of TB with something that resembles a pregnancy test you can run from urine. And then, like the expert machines, there's new versions coming out that are portable. So you can be battery driven, battery operated, so you can really put them in very sort of resource restraint settings. There's also a new diagnostic from MolBio in India that also does drug susceptibility testing, like the Gene Expert in sputum microscopy sensors. So these things are happening now and will be happening over the next 3 to 5 years. So it's yeah, a lot of positive things happening out there.
Morten, you've just done brilliantly because you managed to answer one of the questions that came in the chat about the urine lab.
Right.
We have also actually had a question while I've got you from Deirdre in Poole, who wanted to ask about where FIND gets its money from. How are you guys funded?
Right, so we're funded through government funding and also private funding, like the Gates Foundation. We get a lot of funding from the UK, from the Australian government, from the Dutch government. And then we work also on grants like any other research organization, like the NIH. We get money from the US. We get the EDCTP that was mentioned a bit earlier. That's the big European grants, Wellcome Trust. Yeah, so basically all over the place. And we're very happy for major donations from governments, because that allows us to sort of plan many years ahead.
And just to say to the folks on the line that the UK and DFID in particular have provided really long-term grants to FIND. So when we ask you to write to DFID or to your MP about funding for TB research, we are talking about the money that ends up with Morten's team and that enables them to do that work.
And all the partners we work with across.
And all the partners you work with, precisely.
And we are very happy to support when you are approaching policymakers and people who can push the agenda.
Brilliant. We have got a question from Lucy for Zolelwa. Lucy asks, when you talk about the lack of support that's available for people with TB, can you speak a little bit more about what kind of support people that are going through treatment need?
Yeah, so people going through treatment, so it's basically psychosocial support. So psychological support in terms of depression is one of the known side effects of drug-resistant TB, the medication that is used. So basically things like depression screens, things like just sessions to sort of find out, how the patient has come to terms with the illness, find out, what the medication makes them feel like, find out, what insight they have, and sort of just help them and the need to continue treatment. Because for me, the biggest thing on treatment was wanting to quit and just being scared that, look, I might die if I quit. I might die if I don't quit, So yeah, so psychological support and then social support, because, some of the time when people fall ill, the people that fall ill are, the breadwinners in their homes. So because of the debilitating side effects of the medications, people aren't able, to go back to work and go back and provide for their families. And obviously, the people they're providing for, don't end up eating. And then because they're not providing for their loved ones, they stop the medication and they go back to work as if nothing's changed. And while they're there, they're spreading their form of TB, So obviously the government, can't be giving money to everyone that kind of is struggling with food during the TB treatment. But something that does actually happen in South Africa now is people are being given social grants for the duration of treatment. And I'm not sure when that started, but I think it's become very helpful to people, because obviously to take the pills, you need medication. To go to the clinic, you need money. Everything requires finances. So the support is basically, the day-to-day life of a person, living with TB, and a person who's on the drugs for TB is going through so many side effects on a daily basis, including psychological side effects, So, when I say support, that's the kind of support I need. Things like support groups where, people who are going through the same illness can, talk to each other and encourage each other and educate each other, So yeah, that's what I meant when I said support.
That's brilliant. Thank you for talking us through that. If people are interested to learn a little bit more about what support should be available and what the levels of support that are available to people with TB around the world, my colleague Rachel, who is on the phone somewhere, has recently published a report called Universal Health Coverage Terms and Conditions Apply, which looks at precisely this question of what social support interventions are available to people with TB through their national TB programs. It's a really interesting read, especially keeping in mind how the social support that the government provides to people affected by ill health is top of the news agenda at the moment, with lockdowns in the UK and people losing their employment as a result of it. I think we are well over the scheduled end of the webinar. Thank you so much for joining us today, and we hope that you found the discussion both interesting and hopefully inspiring. There are definitely questions in the chat box that have been left unanswered. We're going to be turning this video, this webinar into a video that we'll be posting online, and we'll include answers to those questions on the website, and we'll circulate them to all participants. If you're not already a member of the Results Grassroots Network, please do consider joining us. We work precisely on these issues that were discussed today and would love to have you as part of the advocacy team. Advocacy is, as we heard today, something that is really, really important and does have an impact. Della has just posted a link in the chat box that you can follow if you would like to get involved. global health is at the top of everyone's agenda at the moment, and we're all, I think, living through quite scary and unprecedented times. Following this call and thinking about the work of Results and our partners like Find, I think the most important takeaways are for us to focus on the most vulnerable and marginalized, to leave no one behind, to ensure we invest in new technology and invest in getting it to the people that need it. So please think about what you can do to support those efforts and to strengthen health systems after you leave this call. I'm very conscious that the audio of the video clips we shared was not quite as good as we'd hoped after our test runs, though that is hopefully an even better advert for you all to go away and watch the full film. My colleague Della is just about to post another link to the film on Amazon, which you are welcome to spend an evening doing now that you can't go out to restaurants. And we'll, as I said, make the recording of today's webinar available on our website. Thank you everyone for joining us. A special thanks to Morten and Zolelwa. I know you're both incredibly busy at the moment, and we really, really appreciate you taking the time to speak with us and to mark World TB Day despite the slight change in plan. And I hope that we can welcome you both at an actual event in London next year. Thanks everyone.
Good night everybody.
Bye-bye.
Thank you. Thank you Zolelwa, Morten and Janneke.
Thank you so much for having me. Bye.
Thank you.
Bye.